Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi semua. Saya Mr. Huzairi Yaakob lah, pada siapa yang tak kenal. So saya datang ke Kota Baru ni berkhidmat sebagai kolorektal surgeon sejak 2020 lah. So sebelum tu pun dekat sini, tapi lepas tu sambung sub lah. Alright, saya ganti Datuk Ahmad Syawani untuk bagi talk kanser. So I cakap dalam bahasa Melayu, okay kot lah. Alright, okay. So apa yang saya nak bagi hari ini adalah pasal kolorektal kanser, update dan screening lah. So apa yang kita hadapi sekarang di Kota Baru ataupun lebih khusus di Kelantan lah. So ni adalah topik yang saya akan cover. So dari epidemiologi, macam mana statistik dekat hospital Kota Baru, latest statistik and basic anatomy yang you all should know. So as a caretaker, ada you doktor, you medical assistant ataupun nurses, at least basic lah, you all kena tahu. And macam mana biasanya pesakit-pesakit kolorektal ni datang, apa dia punya gejala-gejala dia, apa simptom-simptom dia, ataupun lebih spesifik alarming sign yang you all kena pick up. And then healthy population screening, yang ni apa yang diwar-warkan lah. So supaya kalau kita boleh screen mereka-mereka ni, so kita boleh detect ataupun kita boleh kesan kanser ni di peringkat awal. Alright, so this is things yang at least after this lecture you all boleh dapat lah. Okay, so untuk permulaan, biasanya colorectal cancer ni dulu-dulu kita tahu dia among top 5 ataupun top 2 macam tu lah. Tapi over the years it increases until now become number 1. Why I put number 2? Because kalau you compare male dengan female, actually in male colon cancer is number 1. Tapi female sebab dia ada satu lagi organ which is breast, so that's why dia compete between two lah. So in general kalau you see statistik in Malaysia pun colorectal still 1 to 1. So it is alarming. Sebabnya kita tanpa kita sedari, suddenly kita ada colorectal cancer. So in fact in HRPZ we have a lot of staff that have colorectal cancer, in which they come a bit late. Anyway, so lifetime risk 5%. So we take overall lifetime risk, siapa yang dapat colon cancer is about 5% only. And biasanya most colorectal cancer ni dia asymptomatic. Dia tak bagi apa-apa symptom at all. Nanti kita terang lebih detail kenapa dia asymptomatic. You all tak tahu pun you all ada cancer. Biasanya asymptomatic. And bila dia datang tu most of the time stage 3 or more. So nanti I akan terangkan kenapa dia datang lambat. So that's why you all kena pick up much earlier lah. So and one important thing is that colorectal cancer ni one of the cancer that can be detected early sebenarnya. But as mentioned here lah, easy to say than done. Walaupun you kata dia boleh detect awal, tapi it's not that easy. Tapi kita boleh improve lah, that's what we want to do. Alright. So if we see our National Cancer Registry, this is reported from 2007 and 2011. You see the number. So number 1 of course breast cancer, and number 2 is colorectal cancer. As I mentioned earlier, because breast female predominantly banyak kan compared to male, so that's number 1. Anyway, if you see male, so number 1 already colorectal cancer. Sebelum ni kita kata lung cancer number 1, now colorectal cancer become number 1. Alright, if you see gender distribution, you see colorectal topmost in female, of course, breast, but followed by colorectal. Still, number 1 or number 2? High in the rank. Okay. So if we see statistic, male to female, as mentioned earlier, majority colon cancer is male compared to female. In terms of ethnicity, because this one, the data is combination in whole Malaysia, they found that Chinese to have higher risk of having colorectal cancer. One of the thing, maybe they detect much earlier, or they wanted to screen much earlier. Faham tak? Kita ni kita tunggu sampai perut dah gembung baru nak datang kan. So Chinese on the other hand, probably they come much earlier. Dia rasa sikit dia, pergi private whatever lah, because the data collected based on bila dia present kan. So I punya assumption is that one, because they detect much earlier. Not to say that Malay less, tapi maybe Malay ni dia banyak sangat optional. At the end of the day baru dia datang. Population Malay of course lagi banyak kan. So that is something to ponder lah. So your job is to make them aware. So the moment they have symptom or sign, go straight to hospital. No worry. Okay. See, if you see the stage, majority 70 to 80% they come stage 3 or 4. Kan? Example you see in developed country, contoh Amerika kan. So who's the hero of Black Panther? Kan tak tahu kan that apa nama dia tu? But anyway, that fella is having stage 3 colon cancer when he present. So meaning at their level advance of technology for diagnose any cancer pun still late. So one, maybe because awareness. Number 2, I don't think so awareness is problem. Diorang sangat aware kan of any problem. Tapi because of the symptom come much later. Dia datang, dia punya simptom lambat. Alright? So kita punya tugas ni make sure walaupun dia ada sikit-sikit tu no problem. Just refer. Okay, if you see incident, so majority sporadic lah. Sporadic ni maksudnya it developed by itself lah. Ataupun if you want to go into depth, more towards chromosomal instability. So in general, colorectal cancer dia ada sama ada sporadic ataupun inheritary. Kalau sporadic ni biasanya chromosomal instability. Kalau inheritary ni dia macrosatellite instability. I know you will get confused but no problem. Satu, you ingat dia jadi dengan sendirinya. Nombor 2, dia inheritary, family, follow the family tree. Okay, as simple as that lah. Tak payah kompleks nak fikir kromosom apa involve. Alright. Majority developed by itself. However, if you detect or you manage to see patient that happen to have colon cancer in younger age, younger meaning less than 50, you have to be careful. So these patient might have inheritary punya roots lah. So those patient you kena investigate more, tanya family tree macam mana. Kalau dia ada lagi family tree, probably high probability that dia ada inheritary or positive family history. Okay? Tapi in general 70% kalau you check up dia adalah sporadic, jadi by itself is okay. Alright? Unless you detect early cancer. Okay. Faham eh? So other than that, you can have IBD, inflammatory, secondary to inflammatory. All these are secondaries lah. Alright. In general, the incident commonly sporadic, it developed by itself for certain reason. Number 2 is inheritary lah. The one, even inheritary, the percentage only 3 to 5% saja. Very much lower. Walaupun you rasa, katalah, you ambil yang 20% positive family history ni,
you do genetic testing, so you found out actually daripada 20%, only maybe 15%, that 15% is still sporadic. So 5% is still inheritary, meaning to say inheritary ni sangat-sangat jarang. Okay. Okay, now we go to colorectal cancer consensus in HRPZ. This is last year's data. So walaupun COVID, dia tak prevent or dia tak reduce the number. So the number tu around 70, 80, sometimes reaches 100. So I still think that the data probably near 100 lah, because only recently I know how my medical officer collect this data. So there are two ways, or there are three ways whereby you can collect this data in terms of new cases. One, they presented in emergency setting, meaning dia datang di hospital emergency, intestinal obstruction or rectal bleeding, kan? And then you intestinal obstruction, you do laparotomy, buat CT scan whatsoever, you detect patient ada colon cancer. Number two, rectal bleeding. So datang rectal bleeding, you do. So this is one data. Number two, when electively they go to clinic, referred by other center. Kan? Contoh Tanah Merah buat scope, dah jumpa cancer, they refer to my clinic because they cannot do the operation there. Kuala Krai similarly, so they cannot do the surgery, they refer to me. So there is new case in elective setting. Other than that, our normal scope, meaning the patient that we schedule for scope on Tuesday and Thursday, so that's whereby we detect other incident of colorectal cancer, meaning this three way. So if you see three way, since I come to patient, I think we some patient probably miss, especially in the emergency setting. Kan? Bila emergency tak sempat pun nak isi, okay, masuk dalam database. So that's why now I urge my medical officer to do Google Sheet. So if patient come emergency, immediately put the data in. So kalau tak, you habislah kan, you termiss the data. So what I notice, they all suka put later. So at the end of the year baru collect. You faham tak? So you nak retrospectively go back to the January ke? Nak tengok OT book, I think ridiculous kan? So what you do, probably you tengok cancer registry saja. So yang elective dekat scope dekat ni, sometimes you may miss. I tak cakap probably diorang tak buat macam tu lah. Tapi kalau you put later baru you nak collect the data, I think that one is fail in the data collection lah. Okay. Sebenarnya I think more. Alright. So if you see our data, so our data show that every month mesti ada colorectal cancer cases. Mesti wajib ada. As I mentioned earlier, the number probably more, but anyway, so you see at least you have 2 or more cases per month. So then you tak tengok you punya backlog cases yang sebelum ni you belum op, yang patient needed what they call pending chemotherapy, radiotherapy before surgery. So kalau you tengok patient dekat ward ataupun patient kat klinik saya colorectal cancer, I think yang dekat luar-luar tu maybe 70 case semua colorectal cancer. So meaning it is alarming for colon cancer. So in general we have about 74 cases for year 2020 lah. Alright. So the highest in September, I think 13. So you see March kan kita start PKP, still ada number. You see bila kita nak operate ni, tutup apa semua kan, you see how difficult is my situation. So I have to ask other nearby hospital whether I can go there and operate. So they all being operated lah, no problem. Because cancer, we prioritize them for surgery. So yeah, just same data just to show that number. So September, as mentioned earlier, we managed to detect much earlier. Probably at this period PKP patient tak boleh datang kan, So after the PKP tu, this is the search of patient presented. I managed to detect. Alright.
Assalamualaikum, maaf mengganggu. Minta anukan kenderaan yang mempunyai TDX 9223. Minta anukan kenderaan TDX 9223. Sekian, terima kasih.
Alright. So if we see the distribution, so for 2020, slightly more female compared to male lah. But yeah, it still can happen like this. So if we look into the data from 2016 until 2019, but 2020, I don't know, maybe awareness is more in women, so they come, they have we detect much more cancer in female. You see the age distribution. Of course, majority more than 50 years old, but surprisingly, we have more younger age patient that have colon cancer. What we mean by younger, less than 50 years old. So in general, kalau patient at younger age, biasanya the tumor more aggressive, more stubborn. More stubborn meaning even kalau you bagi kemo pun dia tak degih kan, orang Kelantan kan. So dia tak degih. You bagi kemo pun dia macam tu je. Sometimes dia become more bizarre, dia lagi aggressive. So I think I still remember last year I have one patient, maybe 22 or 26-year-old girl, kan? So dia came with intestinal obstruction. We do surgery. Just after 1 month, she has multiple metastasis, and then patient succumb lah. So patient died. So young patient tak sempat bagi chemo pun because dia so aggressive. So you try to catch the tumor, you cannot. So you cannot fight. So therefore, in younger age, you need to be aware because the tumor is more hostile. Dia sangat aggressive. So yeah, age distribution and based on the month, so nothing to highlight as mentioned earlier. So majority is still above 50 years old, but at this particular time, you see from our PKP we managed to detect much earlier. So I still remember because at this period, I encounter a lot of younger patients having colon cancer. I don't know why. Maybe because of the food, kan? I don't know. I cannot blame the specific food, but yeah, it's happened. So I cannot blame budu. I cannot blame chicken chop. I don't know. So I cannot pinpoint specific those things causes colon cancer. So if we go at location, you see, in general, when we talk about colorectal, two different entity, kita tak boleh panggil colorectal cancer. Kita panggil sama ada colon cancer or rectal cancer. Okay? Kalau you nak divide, you can call right-sided colon cancer or left-sided colon cancer. If you say about colon, rectum lah. So you no need to divide upper, mid, lower. Your level, rectal cancer. Rectal cancer, left-sided colon cancer, right-sided colon cancer because they present differently. Yang tu you kena tahu at least lah. Okay, so majority if you see at this location at the left side. You nampak tak? So you see the number, majority left side. Left side include left colon and rectum lah, semua tu belah kiri kan. If you divide the gut or the large bowel right to left, majority of the cancer located over the left sided. So therefore you need to know what are the typical presentation of this left-sided? Okay. Here, same, just to show the number, where is the location distribution. So majority is at the left-sided. Remember that, left side. It's either sigmoid, retrosigmoid, or rectum. Other side, quite rare. Again, same. This is total data 2020. Just to show, you see the number. Rectum or retrosigmoid? Rectum or retrosigmoid? So probably this patient, you know, presented much earlier. So those patients presented later, we only managed to detect the cancer. The patient present with it. Okay, left-sided versus right-sided. You see the yellow bar chart, you see? Right-sided, 80%, majority. So if you see colon or rectum, the distribution is 50-50. So colon and rectum are the same. It's about there. So look back at our data 2016 and 2019, quick go through. So you see the number more or less the same, 2020, 74. It's around that 70 to 80 cases per year. As mentioned earlier, the data can be missed due to some reason. Okay, number of cases. Male and female, as mentioned much earlier. 2016, we have slightly more female. After that, all are predominantly by male. Only for 2020, we have a higher number of female. So in general, it's about, I would say that 50-50. So age 50 years old, you see. So the number are still alarming, meaning higher chances of patient even less than 50 years old can develop colon cancer. Of course, majority is still above 50 years old. So right-sided versus left-sided, you see majority. This is based on the previous data. So 284. So therefore, you need to know what are the classical symptoms of left-sided colon CA and right-sided colon. All right. Colon versus rectum. As mentioned earlier, more of equivocal same lah. So this is the anatomy of our large colon. So start from cecum, ascending, transverse, descending, sigmoid, and rectum. This is basic lah, colon. So can cancer happen in small bowel? Yes, but percentage is very minimal. Maybe less than 1% kot. So usually cancer will happen in colon. So usually it's happening in colon. And majority left-sided, if you divide between transverse colon into two, majority here until there. And majority are here. Majority dekat bawah ni. So the symptom you need to remember. Okay, this is the rectum. So for surgeon, you need to, or for doctors, you need to at least divide this into 3 parts lah, upper, mid, and lower lah. Lower and mid sometimes is very easy to diagnose. Macam mana nak diagnose? Lower rectum. Macam mana nak diagnose? You put your finger lah. You all ni, I notice, you all tak put finger pun. Patient datang PR bleeding, ibu diagnosis hemorrhoid. So I punya lah tengok, okay lah nak scope patient ni hemorrhoid. And I put my finger lah, this is not hemorrhoid, this is cancer. Kan? Kalau you put your finger je, you boleh rasa. Especially in low rectum lah. Memang you boleh rasa. Okay, we talk about etiology. So, and risk factor. I think it is combination of all lah. You tak boleh pinpoint. Macam cakap red meat, animal fat, kan? So orang selalu tanya saya, daging ni boleh makan ke tak kan? Patient tanya kan. Macam ni orang nak jawab. So you have to be smart. You need to remember, daging ni kalau you sembelih daging tu, you ambil daging tu, of course tak ada risk apa-apa lah kan. Because there is no added chemical. Yang ada is processed meat yang you import. Kan, because you nak preserve daging tu supaya tak rosak and things like that. Ataupun bila you masak dekat kedai, tak tahu ingredient apa dia buat. Sebab tu component that added to the meat is more important rather than meat itself. You faham? So kalau patient tanya you, boleh tak makan ni? Of course boleh, tanya saya semua boleh. Patient bengang je kan. Saya cakap semua boleh. Orang kata ni tak boleh, ni tak boleh. So because you don't know, even though daging yang you beli dekat supermarket kan, you tengok daging cantik ni, you don't know what added preservative yang dia letak. Faham tak? So sometimes dia ada letak chemical to maintain the integrity of the meat. So benda-benda tu you tak tahu. And imported meat, you tak tahu apa yang dia dah suntik pada daging tu untuk besarkan lembu ke apa semua. You don't know. So that's why it's very difficult. If you see data in overseas pun dia tak boleh pinpoint. Tapi they found certain chemical in that, especially in processed meat. Adalah chemical-chemical yang ada amino acid yang harm ataupun carcinogen. So those are the one that can cause cancer. Kan, kalau tak kita tak boleh lah bagi orang jual daging kan. Kalau daging tak boleh makan. So it's difficult to say. You need to explain to the patient component in that meat. Contoh kalau proses ataupun imported meat, macam mana daging tu diproses and things like that lah. Kalau kita sembelih daging tu, for me no problem. Kan? Memang dah sasar lah you sembelih daging tu. Orang yang jaga tu bagi rumput, tak ada chemical, so no problem. And of course smoking, diabetes, all this due to depressed immunity lah. Anything yang depressed immunity can lead to cancer. That one is well known lah. Cholecystectomy and uterosigmoidostomy. Tahu cholecystectomy ni kita buang gallbladder lah. Even this also is controversial. Because kalau you tengok dalam literature pun, of course ada yang kata ada association kan. It is probably due to you punya bile, punya exposure to the colon lah. But I not a proponent of that lah. For me is nothing to do with that. So kalau you cakap betul-betul ada, then tak boleh lah orang buat cholecystectomy kan. It's difficult to pinpoint. But study still ongoing lah to prove this. Uterosigmoidostomy ni meaning you use the sigmoid, kita ambil sigmoid tu, kita jadikan dia reservoir. Sebab tu kolon ni tak boleh jadi reservoir lah. Untuk jadi bladder. So kalau you jadikan dia reservoir, dia boleh jadi cancer. Yang tu memang proven lah. Kalau you nak jadikan reservoir untuk keluarkan urine, you kena guna small bowel. Kita ambil ileostomy. So that's why you see, because of that, you know that colon risk of developing CA. Kan? Because dia sangat sensitif. So dia kena urine in chronic pun dia akan dapat CA. So what happen is that uterosigmoidostomy ni, you sambungkan ureter, bladder dah tak ada, you sambungkan kolon, kolon keluar jadi kondui lah, jadi macam bladder lah. So dia boleh di sini. Sebab tu you tak boleh ambil kolon jadi kondui. So you kena ambil small bowel. Meaning you see toughness of the organ. So kolon ni dia tak tough macam small bowel. So dia kena irritant after certain time, dia boleh dapat cancer. Alright? Okay, good. Setakat ni, alright. Tak ni sangat kan? Okay. Other than that, I wanted to highlight is colonic polyp lah. So this is one of our important things. One of important thing for me to highlight to you all lah. So remember this colonic polyp. So if you cannot remember all, you can divide into two saja. Adenoma or non-adenoma. I will elaborate later lah. Okay. Adenoma must know. Adenoma must know. Non-adenoma tak tahu pun okay. Tapi adenoma must know. Why I say must know? Because adenoma ni pre-cancerous. It can develop CA in long run. Long run tu bukannya macam setahun dua. Maybe in 6 to 8 years dia boleh jadi cancer kalau you tak treat dia. Okay? So other than that is non-adenoma lah. So how adenoma become cancer? So this is the process. Dipanggil adenoma, karsinoma, sequence. So dia ada sequence dia. Dia start dengan adenoma, you tak buat apa-apa, adenoma tu akan besar. Lepas tu dia jadi cancer. Remember. So adenoma you kena ingat. So dia ada proses dia panggil adenoma, karsinoma, sequence. Alright. Dia multi-step process. I will elaborate much earlier. Okay, this is the process. You see? So adenoma ni start, dia adalah kromosomal. Macam saya cakap tadi, chromosomal instability. This chromosome sepatutnya dia prevent adenoma to happen. Tapi because of genetic mutation, kromosom tu tak boleh bertugas untuk buang adenoma ni. Sepatutnya dia tak jadi adenoma, dia akan discard lah, dia tak jadi sampai adenoma. Tapi because of this gene ni ada mutation, because of your chemical whatever carcinogen tadi, this gene ni dia defect, dia ada problem. So dia jadi adenoma dulu. So in long run, bila dah adenoma ni dia jadi overwhelming, tak boleh buat apa, gene ni pula rosak. So end of the day dia akan terus dapat cancer. Tapi dia punya proses ni bukan sehari dua lah. So you don't worry pula, oh patient ada adenoma ni kena buat operation. No, it takes years, up to 6 or 8 years baru dia jadi cancer. So kalau kita detect adenoma early, kita buang, so kita prevent colon cancer. Faham? So yang tu yang kita nak try buat sekarang. So detect adenoma much earlier, and then kita prevent colon cancer in future. Okay? So if you do scope, you find polyp. Kan macam ni kan, tengok ni. So you think patient macam ni ada simptom? No, unless bleeding baru ada simptom. Kalau tak bleeding, you don't go to you pegang pun tak rasa. You faham? You pegang tak rasa ni. So in long run, yang dekat this area dia boleh become CA. So yang tu kita kena jaga-jaga lah. So kalau macam ni kita detect, kita buang polyp, patient free from cancer lah. InsyaAllah biasanya dia tak akan dapat cancer. Alright? Quite big kan? So adenoma dia ada specific subtype, but anyway, if you want to remember for doctors, okay. For the rest tu, at least you tahu adenoma pun cukup. So villus is more cancerous lah. So of course commonest is tubular, and they can have tubulo-villus mix, but villus carry high risk of developing CA. But anyway, still the duration is long for it to develop CA. However, for us or for doctors, you need to know these are the predisposing factor. So if you see the size of the polyp is big, histology dia villus kan, degree dia ada dysplasia. Dysplasia ni maksudnya dia dah sel dia dah bertukar jadi sel yang lain kan, yang dia punya architecture dia tak sama. So tu dipanggil dysplasia. Dysplasia ni satu je step lagi nak jadi neoplasia ataupun cancer lah. So satu je step, last step. After dysplasia, cancer. So two step of differentiation dia lah. So number of polyp. Kalau kita nampak big size, histology dia villus, dia ada dysplasia ataupun dia banyak polyp. So these are candidate that we think that polyp or that thing is probably cancerous. Dah ada malignant change ya. Okay. Okay, so now this is just to show that polyp tadi lah. Polyp tu by default dia benign saja, so it can become cancer. So in long run, so no problem. This one because if we do scope, we can just access this polyp. So okay, benign. Alright, so far okay kan? So now we go to the presentation lah. So as mentioned earlier, at least you need to know this. So right-sided versus left-sided. As mentioned earlier, left-sided more common. So right-sided ni biasanya atypical dia datang dengan anemia. So dia tiba-tiba pale, But recently ada satu patient saya lah, so was referred by my wife actually. So dia datang, dia kata ni kawan dia kata anemia kan. Cakap female biasalah anemia kan. Yang pula tu 36 year old, still not married yet, female. Saya cakap, apalah, never mind, come to my clinic kan. So examine, ada mass. So probably CA lah. As simple as that. Buat scope true enough ada mass. Tapi dah operate dah. So meaning anemia, remember the anemia. Walaupun anemia ada banyak cause, remember one of the cause is right-sided colon CA. Okay? And you have weight loss, betul dia ada weight loss, dia ada mass. So why is this happen? Right-sided ni you need to remember, dia datang dengan mass sebab cecum is capacious, besar. So mass tu jadi besar baru kita boleh rasa dia. Kalau dia kecil kita takkan rasa. So bila dia dah besar dia nak feel the cecum tu, baru kita boleh rasa dia. So meaning dia akan datang bila benda tu dah besar. Number 2, tumor dekat right-sided ni dia more ulcerative. So dia bleeding. So dia akan chronic blood loss anemia. Okay. And number 3, biasanya dia tak datang dengan intestinal obstruction right-sided ni. Why? Because the stool consistency, kita punya stool tu dia masih lembut, masih air. So dia tak keras lagi, dia tak blocknya. So selagi ada lubang, selagi tu najis boleh keluar. So dia takkan datang. Okay. So that's typical. You remember about right-sided. Because stool still soft. So stool keluar daripada small bowel tu masih air. So dia boleh lalu. Air akan diabsorb oleh large colon, barulah you punya stool keras. Sebelum tu stool lembut. So lubang sikit pun dia lepas. Okay. Remember that, this typical presentation. Right side, anemia, mass, weight loss, and then they rarely obstructed. Okay. So left side on the other hand, remember, dia very vague, susah nak kata sebab tumor kadang-kadang dalam pelvis kan. Dia abdominal pain yang not specific. Dia ada altered bowel habit. This typical. Altered bowel habit. Sekejap airnya, sekejap tak. Sebab lubang dia kecil kan. Sigmoid is the narrowest part of the colon. Remember. Walaupun stool sikit pun dia boleh block. Dia boleh ada rectal bleeding, feeling incomplete defecation. So meaning dia pergi berak air, rasa macam ada lagi. Berak ada lagi. Because the tumor masih ada dekat rectum. So the sensation nak berak tu akan ada sepanjang masa. Walaupun you dah berak. And they come usually with obstruction lah. Because the lumen is small, najis dah keras, the senang block. Okay. Presentation 20 to 60% present emergency macam saya cakap lah. Because they block. Other than that, dia akan datang dengan rectal bleeding lah. So this is the common intestinal obstruction ni biasanya late stage, definitely late. Profession late stage. So the moment patient have these two, you consider patient to stage 3. The moment they have two. This one still you tak boleh label stage 3. Yang ni is the common presentation. Altered bowel habit, rectal bleeding, so abdominal mass. Nampak tak? Okay, this is tumor. So this is tumor dekat hepatic flexure. Small bowel dah lekat lah kat sini. Because late stage. So you need to do en bloc small bowel resection and then hemicolectomy. Same patient, so they are performing hemicolectomy for that lah because dia melekat kan. And then we join back the small bowel, the colon we remove. Okay, ni tumor yang kita dah buang, kita join balik lah. So ni Hanson anastomosis ni. Kalau you nampak macam ni kan. Ada option is staple anastomosis. So this is how aggressive the tumor. You think how many kilos ni? At least kilo kan. Patient relax, tak ada symptom. Why patient presented late? As mentioned earlier, right-sided. Selagi ada lubang, selagi tu najis keluar. So you nak buat macam mana? Kan late ni. You see how big is the tumor. So still patient tak boleh datang awal. Tapi nanti bincang pasal breast pula lah. For me, I think breast lagi kena concern kan. Dia superficial. Colon of course kat dalam, dia tak boleh nak kata apa lah. Breast ni lagi all kena awareness so that you boleh detect much earlier. So okay, this is another tumor. Post right hemicolectomy, extended right hemicolectomy specimen. This is tumor hepatic flexure. So as for the distribution, 70% ataupun majority dekat left sided lah. So right sided tu not really there. Tapi kalau dia ada right sided, dia typical presentation macam yang cakap tadi. Anemia, mass, and then weight loss and things like that. So sama distribution, majority at this particular area, left sided. You cut the transverse colon into half, majority dekat sini lah. And to be more specific, majority is still low side. Okay. Same the distribution. So this is rectal, tadi colon. So kalau rectum spesimennya macam ni lah. Ni spesimen yang pelik lah ni. So because rectum panjang tu kan, so this is the tumor. So this is vessel or the pedicle. So we cut 5 cm above, 5 cm below. So this one ni anus ni kita buang anus sekali. APR specimen, tumor dekat sini. So you tak boleh salvage dia, you kena buat APR lah. So all these tumor mana yang low ni macam yang cakap tadi, the moment you put your finger you boleh rasa. Okay, pathology in term of dia punya karakter ataupun dia punya phenotype dia, it can be ulcerating, majority ulcerating ni right sided, and then therefore dia boleh bleed. Annular ni biasanya left sided. Okay. Okay, histology, poor sensation, okay lah, I think. Okay, in term of spread, kalau dia datang lambat, dia boleh spread locally. Maksudnya dia boleh infiltrate nearby structure lah. Kalau dekat hepatic fracture, liver boleh kena, gallbladder boleh kena, posteriorly kidney, duodenum. That's why kita kalau boleh detect much earlier, so that kita punya surgery tu tak kompleks sangat lah. Taklah susahkan I kan, operate ada kena. Padahal kena buat colectomy je. Bila kena pancreas, kena Whipple lah. So patient akan lagi morbid lah. Morbid to the patient. Okay. So this how the picture of cancer inside. This is early cancer. Even early, the treatment is still the same. So see ulcerative type. Okay, staging, medical officer kena tahu lah kan. So we use AJCC 7 edition. Senang je ni, I nak ajar you, at least I ajar you today, you remember forever lah. So for T, you tak payah angkat T1 sampai T0 sampai TX ni tak payah lah. So T1, 2, 3, 4. T1 ni submucosa. Submucosa atau you nak cakap mucosa pun okey. T2 muscle layer. T3 serosa yang luar sekali, wall luar colon. T4 adjacent structure. Dia dah keluar daripada serosa tu, dia pergi nearby structure lah. Senang kan? T1 sampai T4. Okay. Submucosa, muscle, serosa, outside, nearby structure. Alright, ni medical officer kena tahu lah. So, lymph node. N1, N2. You tahu N1, N2 je. N0 pun senang je kan. N0 kalau tak ada lah. So, N1 ni less than 4. N2 more than 4. Senang je colorectal cancer ni. Tapi berapa you nak lymph nodes for colon cancer? To have adequate staging, 12. Contohnya kalau I buat surgery, so lymph node tu datang, 9 saja. So we call that incomplete nodal staging. So bila incomplete nodal staging, I dapat 9 saja. Lagi 3 kan sepatutnya jadi 12 kan? We consider 3 tu positif. So kita treat as stage 3. Faham? So therefore it's quite important to see the HPE lah, berapa lymph node. So kalau you dapat lymph node 12, okay. No need. So you boleh treat dia, kalau lymph node negatif lah. Tapi kalau dapat tak cukup, you dapat 5 je, you kena treat lagi 7 tu as positif. Because you tak tahu kan. Tapi sebelum tu you boleh ask you punya patologi. Boleh tak cari lagi lymph node? Sometimes dia malas. Bukan malas, dia quick je kan. So dia boleh slice balik, dia cari balik lymph node tu. Maybe dapatlah 2-3 lagi. Tapi kalau tak cukup, still you kena bagilah chemo. Ni distant mat. You all tahu ada mat atau tak ada mat. M1, M2 je. Actually ada M1, MB. Never mind. Itu M1, M2. Okay, stage So based on that, kita tengok stage. Okay, to remember this easy, stage 3 dulu. Kalau the moment dia ada lymph node, stage 3, habis cerita. Okay, so the moment dia ada metastatic, stage 4. So yang cara remember, you kena remember dekat stage 3 dulu. Stage 1 and stage 2 ni dia based on T saja. So T tadi kan saya cakap kan, kalau mucosa dengan muscle, stage 1. Kalau dia involve nearby structure dengan serosa, stage 2. Okay kot? So since colorectal cancer ni, you remember ni lah, cukup dah. Why you need to remember this? Because for prognostication lah, prognostic. So kalau you stage 1, stage 2, you have about 90% prognosis, 5-year survival. And even now, stage 4, we talk about colon cancer and liver metastasis. We can have up to 30%. Actually, kalau you tengok betul-betul, kalau stage 4 to 15% 5-year survival je, maybe 5 to 15. Tapi kalau now kita boleh buang kanser dekat kolon, kita buang kanser dekat liver juga. Kita so advanced. So kita can increase the survival up to 30%. Okay? So these are the prognostic indicator lah. Kalau you nampak all these indicator, probably this patient have poor prognosis. Okay? So investigation. So remember the first investigation, of course, history and physical examination. Remember. So I think you all scared of your finger. I don't know why. Kalau you rasa takut dia bocor, pakailah 2 glove kan. Sebab anyway, so you have to do per rectal examination. So not just to feel the mass, tapi you sometimes you nak tengok the stool. Kan kadang-kadang you nampak ada darah. So meaning there is something above. Okay, remember, just do per rectal examination. Don't just see external, okay, hemorrhoid. Padahal you masuk ni jumpa benda lain kan. So in term of investigation, so FOBT, CEA as baseline follow-up. This is for follow-up lah, CEA. FOBT ni untuk screening. So you all macam mana you all buat screening? So you buat FOBT. Screening ni you need to remember is for asymptomatic patient. Yang mana above 50 asymptomatic, dia tak ada apa-apa, you nak buat screen, no problem. What the higher limit? 80 years old. Above 80 tak payahlah kot. Kalau you nak buat juga, you tanya nak pergi hospital tak? You all ada buat, baru ni dapat kat klinik, 80 years old. Datang kat klinik, doktor saya tak nak buat apa-apa pun. So useless lah you buat IFBT, patient tak nak apa-apa. So you kena tanya patient juga, are you willing to do the scope? Kalau tak, you all punya study tak ni kan. So these are the modalities for investigation. FOBT, screening untuk asymptomatic. The moment patient symptomatic, colonoscopy lah. Edema only untuk patient yang you tak manage to colonoscopy. Alright, CT scan, MRI, yang ni semua untuk staging of the disease lah. So screening, as mentioned earlier, you remember this term? Screening adalah proses ujian untuk patient yang asymptomatic. Screening yang available now dekat your punya center is IFOBT. So yang tu yang you boleh buat. Okay, faham? So asymptomatic, kalau ada symptom, dia high risk, dia ada family history, what not, blah blah blah, you don't do screening, you do surveillance. Surveillance ni test yang kita buat pada patient yang dah ada colon cancer, yang dah operate apa semua, ataupun at increased risk, strong family history, very strong family history. So you request for surveillance. Surveillance scope lah kita panggil. Screening kita tak panggil screening scope, kita panggil diagnostic scope. Sebab kita takut you all salah label. Ni buat screening colonoscopy. No such thing as screening colonoscopy. So kita panggil diagnostic colonoscopy. So the moment dia positif, after you screen IFBT, kita panggil diagnostic colonoscopy. Alright. So okay, this is risk group. Kalau you nak stratified dia punya risk based on age or high risk ni kan. So all these high risk ni, you panggil surveillance scope. You request for surveillance scope. You tak payahlah buat IFBT. You nak buat ke? Dah high risk. Symptomatic pula. And then you buat IFBT. Macam tak masuk akal kan? I tahu sometimes you nak buy time ke. Tapi no problem. Just refer for surveillance scope. Okay. Justification for screening. Sebab apa kita ada program screening? Macam kita cakap tadi lah, colon cancer among top 2. So top 1 for male, top 2 for female, kan? Because breast cancer number 1. So because dia common cancer, so kita boleh screen patient yang colon cancer. So again, the leading cause. So survival related to clinical and pathological stage. Kalau you dapat screening awal, you detect awal, prognosis dia makin baik, kan? And remember, because most asymptomatic. Betul tak? So that's why you kena screen. You tengok ni 50 years old, macam tak bagus. Screen je, no problem. Kan? Alright. Kalau screen, katalah you found IFOBT positif, this patient boleh dapat IFOBT positif sebab dia boleh bleeding kan daripada polip. So kalau kita jumpa polip ni, kita boleh buang. So you prevent one cancer. So this to talk about FOBT, FOBT. So yes, it have sensitivity about 30 to 92%, specificity of 90 to 99% lah. But anyway, I don't want to touch more about this. Traditionally kita guna guayak base kan, yang tu have more what they call negative. Tapi now kita guna IFOBT, so kita dah boleh overcome those false positive result. So compliant, remember, kalau nak buat effective screening, comply. So meaning kalau patient tu boleh ikut you punya screening protokol, okay, buat IFOBT, next you buat kolonoskopi, then you punya screening akan jadi efektif. Tapi kalau you tanya ni, di scope dia tak nak buat, and then you rugi sajalah. So and then you boleh increase public awareness so that they come much earlier. Okay. Then you boleh educate the patient. Kalau dia positif, there is further investigation that can be done to detect or to diagnose any colonic problem. Alright. So bowel prep, this is our bowel preparation yang dekat our hospital lah. So you all nak tahu ke ni? But anyway, kita ada 2 days preparation. So 1 day before, you cannot allow patient to take any vegetable or fruits. Only water and makanan yang kuantiti sederhana lah. So 1 day. Different hospital ada different preparation. You tak boleh stick to one. But anyway, this is general lah. And then for next day tu, patient tak boleh makan terus after subuh tu. Only clear water. And pukul 9 dengan 3 petang, dia bagi laxative lah. Of course, sometimes patient tak boleh nak fulfill this, you need to admit the patient lah. Cumanya yalah, sometimes you nak suruh patient tak makan ni pun, biasanya fight dekat sini lah. I cakap sahur tu you makan lah. Kat sini kan. Lepas tu nak puasa-puasa lah. Okay, this is our scope for kolonoskopi panjang. Kita boleh sampai ke sikum. Kita boleh tengok appendix, no problem. Tengok item pun kita boleh masuk. So bila where is the end of kita sigmoidoskopi, biasanya sampai sini ataupun splenic fracture lah. So complete kolonoskopi sampai sikum ataupun terminal ileum. So these are the view of normal kolonoskopi. Cantik je kan? This transverse colon because of the shape, kita orang tahulah this cecum because that is the appendix. So this is part of the colon. So you easily identify kalau ada anything. Ni kita boleh buang, ni kita boleh buang. Semua boleh buang. Easily removable. So that's why detect early, easily removable. Detect lambat, tak boleh nak buang lah. Tak boleh nak exercise, you kena buat colectomy, buang bowel tu. Okay. So this is another disease that can be diagnosed by colonoscopy. Dia panggil multiple polyposis. Kalau macam ni, you have to remove all the colon lah. Tak boleh buat apa-apa lah. Dia panggil FAP. So this is cancer. how it look like from the colonoscopy. Huh? You see the loop is malignant, kan? Contact bleeding, almost circumferentially, and then the lumen is obstructed. You tengok pun you tahu ni cancer lah. At glance pun you boleh tahu. Okay? I think that's all. Any question? I just got reminder 5 minutes more. So on time, huh? So any question from the floor? Any burning question? Please ask. Okay, one question. Baca, okay?
Saya ada patient yang ambil
Okay.
lepas tu kita kostok lah untuk bagi siap kan. Lepas tu untuk bawah prep tu kita tak ada but ni kita bagi bersama dia tu.
Yes. So if like that, as I agree, bisakodil is not enough for bowel preparation. So you need to have at least 2 item. It's either you use Fortran atau polyethylene glycol ataupun you ada sodium phosphate ni lah. For complete scope, you tak boleh bisakodil. Nanti bila you slow, you akan nampak stool je. No point kan? The tumor can hide behind the stool. So kita tak nak benda tu happen. Let's say you have those problem, you need to ask the patient to go to hospital and take the medication. Faham? Or go to colonoscopy room to prescribe the medication. Dia boleh pergi ke janganlah suruh patient, maybe suruh anak dia kalau patient tak larat kan. Suruh anak dia pergi ke colonoscopy room and get prescription of bowel preparation. That is my suggestion. You have no way you nak bagi bisakodil 5-6 biji untuk keluarkan semua. No, it will not work. So my suggestion, if things happen like that, so you ask the family members to bring you punya IFB to go to hospital, saying that you got the appointment and then you want to get the prescription for bowel preparation. So I think that will solve the problem. Kalau tak dapat tu, you tak boleh buat scope. Redundant je, rugi, you book and then no point. Any question tak?
Banyak tapi sampai ke hospital at least kalau primer boleh benarkan dia ada
At least you ada stock lah, meaning I don't know, then you have to deal with JKN lah. So maybe certain patient, cumanya macam I cakap tadi, the instruction is there. So perhaps kalau you nak ada stock to your center, you must know the bowel preparation that we did in our hospital lah, macam yang tadi tu. Dah ada. Good kalau dah ada ni then okay. Cumanya you need to remember, you kena evaluate juga whether patient tu suitable or not for bowel preparation at home. So yang tu you can take into consideration lah. Kalau you tahu ni patient ni tua ni, you prep kat rumah, dehydrated, flat. So kita takut they affect you lah. So macam kalau kita dekat sana, we always evaluate that lah. Kalau you rasa okay, patient boleh fit young kan, so no problem. And we hope that you give the similar message to them macam apa yang kita bagilah. Kita punya assumption sebenarnya tak tengok you dekat district kan, cakap macam mana you all bagi bawah prep kan, so kita tak tahu. Tapi kalau you boleh standardize benda tu, insyaAllah okay. Ini ada burning question? Remember right sided, left sided, remember that. So we hope that we can detect much earlier cancer. So we can detect polyp. We do polypectomy, patient will not suffer from colon cancer. Any other question? Test, nak buat apa? Okay, remember to put your finger, don't shy. If you afraid of you punya koyak, pakai 2. I pun pakai 2. Walaupun dulu my previous consultant in ada hospital marah kan, "Oi, kenapa pakai 2? Sensitivity is low." I said it's okay. I don't want it break kan. Sekat gloves sangat fragile kan. You koyak sikit pun dah koyak. So lepas tu nak makan nasi pula. Tak naklah put appetite after tu kan. So my message is pakai dua is okay. You nak detect je, sensitive is not sensitive is not the issue. As long as you do PR, you rasa tak ada low rectal tumor. Because banyak lah cases yang kita dapat hemorrhoid. Tapi lately I tengok you all adalah buat apa rectal examination which is good. Yang tak buat tu I frust lah. Hemorrhoid kan. In fact datang dah tahu 2-3 bulan lepas, 6 bulan lepas kan datang hemorrhoid. Just put one finger, it's okay. Kalau you tak put finger, you takkan dapat. Especially low rectal tumor. Memang dapat punya. Mesti you rasa. Okay, any other question? If no question, I give back this mic to the chairperson. Thank you.